All right, we have now come to the part where we will discuss different surgical treatment methods in patients with LUTS. Here I have drawn a picture of the lower urinary tract. We have the bladder, we have the prostate, we have the pelvic floor and external sphincter. We also have an internal sphincter or bladder neck. A normal-sized prostate is around 15 to 20 milliliters of size. 15 to 20 milliliters. Patients with LUTS, due to a small, normal or slightly enlarged prostate, that is 15 to around 30 milliliters of size, usually have a problem just with the bladder neck. In patients with problems from only the bladder neck, the best treatment method is to do a very small incision of the bladder neck. An incision of the bladder neck means that the surgeon cuts the bladder neck in two pieces. That means that this small and narrow opening causing problems and symptoms from the lower urinary tract will now open up, and it'll be much easier for that patient to urinate, and the symptoms usually will subside. However, if the prostate is a little bit larger than this that we just discussed, that is about 40 to 60 milliliters of size, and you can see it is larger written and painted here now also, then it is too large for just an incision when it comes to treatment. In this case, we have to take away pieces of tissue. That is called resection. So in these cases with a prostate that is moderately enlarged, 40 to 60 milliliters or something like that, we have to do the resection. We do the resection trans-urethrally. Therefore, the procedure is called trans-urethral resection of the prostate, TUR-P. Okay, we go through the urethra and then we cut out piece by piece by piece of the obstructing parts of the prostate. You can see that there's quite a long obstructive part in this case. And then we take the other side and we cut away piece by piece until everything that obstructs is resected. The end result will then be and look like this. Now you can see that all the obstructive parts of the prostate in the moderately enlarged prostate are resected and gone. This patient will now be able to void very easily through this area, and hopefully the symptoms of the lower urinary tract will disappear. There is, however, some small drawbacks to this, and that is that this little dot I have done down here, the ring you can see, this is where the ejaculate comes out when the patient has ejaculation. Now there is nothing to stop the ejaculate from going the wrong direction up into the bladder. That is called retrograde ejaculation. All patients going through this type of surgery has to know about this side effect. That is trans-urethral resection of the prostate. Even experienced urologists cannot operate and resect a prostate faster than about 0.5 to 1 gram per minute. This means that in patients with very large prostates, larger than 100 milliliter, the operating time, if doing and performing a resection, will be so long that it will be dangerous for the patient. Therefore, we have another option in patients with very large prostates. We have the adenoma enucleation. Adenoma enucleation means that the adenomas of the prostate will be enucleated. Nucleus, like a nucleus, it will be taken away. And this is not performed through the urethra like the trans-urethral resection. Instead, it will be performed through the abdomen. There are different techniques here when doing this adenoma enucleation, but an easy and simple type of adenoma enucleation is when you go through the bladder, put down your hand in the prostate urethra, and then carve out the adenomas with your finger. You enucleate the prostate. This will lead in the end to the result looking like this. It resembles pretty much what it looked after the trans-urethral resection, as we discussed earlier. It will be empty here, and this patient will experience a great relief urinating after this procedure. It can be demonstrated using an orange. An orange contains a lot of flesh inside, like if you have a prostate. So let's say that this is a prostate right now. And we open up the bladder, put down our finger in the middle of the urethra, and then we carve out the prostate tissue with our finger. And suddenly we stand there with the prostate in our hand, and it will look like this afterwards. It's a much faster procedure in large prostates than the trans-urethral resection. Therefore, we do this procedure instead. So far, we have mostly discussed surgical therapy for emptying symptoms and emptying problems. So you might wonder, does the urologist have any surgical therapy for patients with storage symptoms? Yes, we do. Some of the treatment methods for storage symptoms are intravesical treatment methods. We sometimes use botulinum toxin, which is a toxin that we can inject underneath the mucosa in the bladder. You know that botulinum toxin is a neurotoxin, and it will reduce the nerve traffic from the bladder. And it also will relax the muscular layer of the bladder. So this will have an effect on urgency and frequency and urgency incontinence. We can also flush the bladder with different types of pharmacological agents that can bind to the mucosa and act on different types of irritating symptoms inside the bladder. For patients with incontinence, we can tighten up the bladder neck and the urethra with different surgical methods, like for example slings that lift up and tighten the pelvic floor and the bladder neck. And we can also inject substances underneath the mucosa in order to tighten up and reduce the incontinence. So we have lots of different methods for storage symptoms as well.